I would like to invite Professor Tang Hongren to the stage. He's the current director of the Department of International Medicine of奇美Medical Center to introduce our last speaker. Thank you.
Good morning, ladies and gentlemen. I'm Professor Tang Hongren. It's my honor to introduce the next speaker, Professor Susan Lee. Professor Susan Lee graduated from National Yanmin University School of Medicine and have advanced study at London and the National Taiwan University for PhD. Actually, she is not an outstanding specialist in AIDS. She is also an expert about microbacterial infection and the multi-drug resistant organism. She has many publications and clinical study in recent years. The most important of all, she dedicated herself on Zheng Delin Foundation for the establishment of infectious disease treatment guidelines in Taiwan every year. So her topic today is prosthetic joint infection about next generation sequence and the case sharing. So please join me to welcome Professor Lee.
Thank you for the kind introduction from Professor Tang. It is my honor and pleasure to have this opportunity to present the interim report of Taiwan Metagenomic NGS Multicenter Study Group on pathogen detection in periprosthetic joint infections. Periprosthetic joint infection remain a difficult and challenging complication of joint arthroplasty surgery and is reported to occur in up to 2 to 2.4% of cases. Successful treatment requires early and appropriate antimicrobial therapy. However, this remains an even higher challenge for cases with culture-negative prosthetic joint infections. The prevalence of culture-negative prosthetic joint infections ranges from 5 to 42%, with an estimated true incidence of 7 to 15%. 85% of culture-negative cases may be due to fungi and mycobacterial, and 15% bacterial, with the majority being due to fastidious bacteria such as Brucella and Coxiella burnetii. In addition, cultures of synovial fluid and intraoperative tissue, which is the current standard for pathogen detection, can have a high rate of false negativity of 17 to 53%. Therefore, metagenomic NGS technique is particularly useful in cases of culture negative, where traditional microbiological cultures may fail to identify the pathogen. Previous mNGS studies have shown that the results are highly concordant with microbiological cultures in greater than 96% of cases, though these studies have been very limited in sample size. In addition, for cultural negative prosthetic joint infections, NGS may additionally detect 16% of pathogens. Also, NGS has an additional value in detection of bacteria with low volume of samples, such as the aspirated synovial fluid preoperatively. So our study is a multi-center prospective clinical diagnostic trial that aims to compare the performance of metagenomic NGS with conventional microbiological testing for the diagnosis of periprosthetic joint infections. Our hypothesis is that mNGS will perform superior to conventional tests. A total of 9 hospitals across Taiwan participated in this study, including 5 from northern Taiwan, 2 from mid, and 2 from southern Taiwan. Dr. Wang Huishen from National Taiwan University Hospital is the lead principal investigator. The primary study endpoint is the difference in the rate of pathogen detection using mNGS compared with conventional tests, and the secondary endpoints including the assay performance of NGS and also the number and proportion of infectious diagnoses made using the NGS assay. The inclusion criteria includes adults aged over 20 years of age who sign informed consent, and that the infections will meet the criteria and definitions of the European Bone and Joint Infection Society and the European Society of Clinical Microbiology and Infectious Diagnosis for prosthetic joint infection. The definition of prosthetic joint infection, according to mNGS estimate, is that if any one of the positive findings will confirm the infection, including sinus tract with evidence of communication to the joint or visualization of the prosthesis, or joint fluid analysis with leukocytosis of greater than 3,000, or a predominant of polymorphonuclear sites of greater than 80%, or at least 2 positive samples, cultures, intraoperatively of the joint fluid or the tissue with the same organism, and or histology examination showing at least 5 neutrophils in at least 5 high-power fields, or presence of visible microorganisms. Infections are considered likely if there is any combination of the criteria within the A section or the B plus the B section, which include radiologically sign of loosening or previous wound healing problems, recent fever or bacteremia, purulence around the prosthesis, or an elevated C-reactive protein of greater than 10 milligrams per liter, plus one of the B criteria of leukocyte counts of greater than 1,500, or predominant polymorphonucleosides of greater than 65%, positive cultures on an aspirated joint fluid, or at least 1 single positive sample of intraoperative cultures of either the joint fluid or the tissue, histological presence of greater than 5 neutrophils in a single high-power field view, or a nuclear imaging that shows a positive scan, WBC scintigraphy. Exclusion criteria include women who are breastfeeding pregnant, or those patients with visual or hearing impairment that may interfere with compliance with the testing procedures, or clinically or laboratory findings are insufficient to determine infection status, obvious contamination of the specimen, or concurrent diseases or other conditions that are deemed by the investigator that might influence the patient may be unsuitable for the study. Immunocompromised conditions such as HIV infection with a low CD4 cell count of less than 200, or transplant patients are also excluded. Patients with drug abuse or alcohol abuse were excluded, and also those with a synovial fluid volume of less than 2 milliliter that may be insufficient for diagnostic testing were also excluded. The study aimed to enroll 80 cases, and I will be reporting on the preliminary report of the first 21 cases. The primary endpoint looked at the difference in the pathogen detection rate between NGS and the conventional test, showing that a metagenomic NGS has a high pathogen detection rate of 66% compared to 28% using conventional microbiologic tests, showing a significant difference of 38%. Results were concordant in 52% of cases and discordant in 10 cases. Of the 10 cases that were discordant, only 1 case was NGS negative and culture positive, and that case was a case of Candida parasilosis. In cases where conventional cultures were negative, NGS detection rate was high, up to 60%. Overall, infectious diagnosis made using clinical NGS in prosthetic joint infections were 95%, either identifiable pathogen or negative. The secondary endpoint include assay performance of the NGS and showed a high sensitivity of 83% and high negative predictive value of 85%. The low specificity and positive predictive value occurs because the gold standard using conventional microbiology is not the optimal diagnostic test. And this shows that NGS actually may perform better than the microbiological tests. The other secondary endpoint include the number and proportion of infectious diagnoses made using the NGS assay, and shows that in 45 samples from 21 patients, overall detection of pathogen was 50%, and pathogens detected from NGS only accounted for 20%. And the overall difference between the two assays was 22%, showing that NGS has a higher detection rate. The most commonly detected bacteria using NGS in prosthetic joint infections include Staphylococcus aureus and Staph epi and Staph capitis, followed by QT bacterium, Acinetobacter, Escherichia, Corynebacterium, and Klebsiella. This is the list of pathogens detected, comparing NGS with the culture results from the different patients. So we find that in our study, NGS had a high rate of pathogen detection of 66% compared to 28%, with a difference of 38%. This was comparable to other studies done previously in China, Shanghai, where the NGS also detected around 61% of the pathogens, and a lower difference was due to a higher culture rate. A recent meta-analysis of 10 studies, including 955 patients, to assay the performance of NGS versus culture in prosthetic joint infections, found that the performance was high, with high sensitivities of 93 and specificity of 95%, positive likelihood ratio of 18, and negative likelihood ratio of 0.07. In this study, there was a high accuracy for the diagnosis of NGS in the diagnosis of prosthetic joint infections, and particularly in culture-negative cases, the NGS was able to diagnose a further 52% of the pathogens. So in conclusion, periprosthetic joint infection is a devastating complication following total joint arthroplastic surgeries with poor prognosis. Therefore, identifying accurate pathogens using a rapid diagnostic method such as mNGS is important to allow early and appropriate antimicrobial therapy to improve outcome. Our study showed that NGS had a high overall pathogen detection rate of 66% and an increase in difference of 38% compared to conventional cultures, and provided a conclusive result in 95%. In addition, for culture-negative prosthetic joint infections, pathogens were detected in 60% of cases using NGS. Therefore, metagenomic NGS technique is a useful diagnostic tool for rapid, accurate detection of pathogens in prosthetic joint infections from our preliminary study results. And that concludes my talk. Thank you.
Thank you, Professor Li Xin-rong, for kindly sharing for the PJ on MCT trials. Thank you.